Welcome to Telehealth HIV's webinar on telehealth and COVID-19 implications for HIV care and treatment delivery. Today's webinar is being recorded and will be available on demand within 24 hours after the conclusion of the webinar today. You will notice on the bottom of your screen there should be a Q&A box in which you can submit questions to our speakers throughout the presentations today. At the end of today's webinar, we will be facilitating question and answer at that time. My name is Michael Schenkel, and I'm Senior Director of Capacity Building with HealthHIV, and I would like to welcome you to today's webinar. Recent expansions to federal telehealth coverage, policies, and regulations are changing the landscape of virtual HIV care delivery. This webinar will showcase two programs that are using telehealth to provide HIV care. The presenters will discuss the impact of recent policy changes and strategies for health organizations and community-based organizations to quickly implement virtual care in the era of COVID-19. First, our team at HealthHIV is excited to announce the launch of a new professional services program, TeleHealthHIV. HealthHIV has been working in the area of telehealth for several years. TeleHealthHIV program provides capacity building assistance to help healthcare and community-based organizations to plan, implement, and expand telehealth services for HIV prevention, care, and treatment. In addition, Telehealth HIV provides access to educational webinars, e-learning programs, and resources to support the development of telehealth services across the HIV prevention and care continuums. To access these resources and to request technical assistance, please visit healthhiv.org/telehealthhiv. Telehealth HIV capacity building assistance activities include, but are not limited to, conducting organizational assessments of capacity and readiness to implement telehealth, selecting and securing funding for telehealth programs for long-term sustainability, identifying reimbursement opportunities and payment barriers, making decisions about telehealth systems, including hardware, softwares, and opportunities for community partnerships, identifying telehealth models that work best within an agency, adapting workflows and developing policies and procedures for new and existing telehealth programs, and developing internal trainings for staff to adopt telehealth workflow and systems. Additionally, we can help create client and patient education materials tailored to telehealth services. I would like to also introduce my colleague, Anna Clayton, who is the Capacity Building Manager who manages our Telehealth HIV program, and she'll be helping me to co-facilitate today's webinar. Our other two speakers today will describe their telehealth programs for HIV care. One program is within a rural setting, and the other is an urban model. Michael Murphy is the CEO of Medical Advocacy and Outreach in Montgomery, Alabama, and Dr. Ritu Grewal is the Medical Director of U.S. Health Family Medicine and Pediatrics, Bay Meadows in Jacksonville, Florida. Before we transition to their presentations today, Anna is going to provide a brief overview of the telehealth and policy changes that have occurred under the public health emergency for COVID-19. Anna?
Great, thank you, Michael. So by the end of this webinar, participants will be able to identify changes to telehealth policy and reimbursement as responses to COVID-19, identify applications of telehealth to HIV care and treatment, and describe options for implementing telehealth for HIV care during the COVID-19 pandemic and beyond. So as a brief review of telehealth, telehealth is a broad term that describes a modality for delivering healthcare services via information and communication technologies. Today, our speakers will describe telehealth systems that mainly use video conferencing technology in which the provider and patient can see each other. However, there are many other forms of telehealth that do not involve video but allow providers and patients to connect and share information. Telehealth is greatly beneficial to clients living with HIV. It increases access to HIV prevention and care services by reducing barriers such as time, transportation, and stigma. It also increases clients' engagement within their own healthcare. Especially when video conferencing techniques are used, patients and providers can maintain a strong relationship while connecting remotely. So as we've seen in the past few weeks, the COVID-19 pandemic has prompted federal policy changes to restrictions on telehealth. We will now review the most pertinent policy developments for Medicare and for HIPAA. So let's start with Medicare. Prior to COVID-19, Medicare coverage for telehealth was restricted to certain services and locations. It was only for clients in designated rural areas, and they had to conduct the call from a medical facility, such as a clinic or hospital, and not from their home. In 2019, Medicare did make payment available for brief communications called virtual check-ins, and Part B covered e-visits, which are online patient portal visits. As part of the COVID-19 response, under the 1135 waiver, Medicare now covers telehealth visits from any location, an office, hospital, or even the client's home. It covers services by more providers, including doctors, nurse practitioners, clinical psychologists, and licensed clinical social workers. This waiver also gives healthcare providers the flexibility to reduce or waive cost sharing for telehealth visits that are paid for by federal healthcare programs. The purpose of these changes is to keep clients at home whenever possible in order to save space in healthcare settings and prevent potential exposures to COVID-19. Finally, as part of the federal COVID-19 response, there were also changes made to HIPAA policy. Of course, typically, HIPAA enforces that protected health information is protected to the greatest extent possible, with penalties for noncompliance. Covered entities need to use only applications that are HIPAA compliant and need to have business associate agreements with third-party communication platforms in order to be HIPAA compliant. In response to COVID-19, the Office of Civil Rights announced that it supports the use of telehealth during the national emergency in order to keep patients out of clinics and manage their health from home. Their notification of enforcement discretion means that they will not impose penalties for HIPAA violations while providers are delivering telehealth services in good faith during COVID-19. This covers all telehealth services. In terms of HIV care and treatment, that would include medical care, adherence counseling, case management, etc. As far as platforms, covered healthcare providers can use any non-public facing platform that's available to them to communicate with patients. So that would include Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, Zoom, Skype, etc., without one of those business agreements. These new regulations really rely on providers' professional judgment for protecting PHI to the best of their ability, while keeping patients out of healthcare spaces whenever possible. Both of these federal policy changes provide greater opportunity for health organizations to stay connected with their clients using the technology that's available to them. I'm now going to hand it over to our first speaker, Michael Murphy from Medical Advocacy and Outreach, to describe their telehealth program in Montgomery, Alabama. Michael?
Thank you, Anna. I appreciate it. I want to, first of all, send greetings from the state of Alabama. We're, like you all, are doing our best to kind of deal with the new realities and to still serve all of our recipients and patients to the best of the ability. So I'm very happy to be able to share what we're doing at MAO. I'm going to go through my slides early on fairly quickly because for some of you, you've heard my program before, so it's mainly just a background of information. And then I want to focus more on the latter part and talk a little bit about more practical application on how we're using telemedicine. So we are based in Alabama. We're a 501c3, a nonprofit. Some people think that we may be an FQHC, but we're actually not. We offer a variety of services through the Ryan White Care Act program. We're a Part C grantee, and then we're also doing Part B provision and Part D provision through grantees here in the state of Alabama. Our demographics, just to give you a little feel, about 76% of the men, women, and young people we serve identify as Black or African American, and then the next largest group would be individuals who identify as white or Caucasian, and they're about 21%. We are about 66% male in our recipient core, but we actually have about 33% cisgender women, and that number actually continues to grow. And some of that's based on the fact, I think, what we see in many rural areas in the South especially, is that women are oftentimes even higher in rural counties and rural areas when dealing with HIV. And then also to note, among our folks that we're seeing, 59% are identifying as heterosexual, and that's probably close to it as a self-identification because of sheer number of women we're serving. We can look at 4 quadrants of what we do: medical, social, education, and behavioral. I won't belabor these, but into the medical, I'm very happy to say we were able to do dental clinic, and we're able to have a pharmacy in-house to serve our folks. We also do PrEP, and we use in our telemed program for our PrEP, but we're also doing an NPEP program working with sexual assault sites within our coverage area to make sure if they have a referral that we can serve them in a rapid manner. We also, under the education, we are the AETC for the state of Alabama under the Southeast AETC in Vanderbilt, and that's been great for us because very few community-based organizations serve in that capacity, so we're very honored to be able to do that. And then, of course, we are seeing a rapid expansion in our behavioral health program in so many underserved areas. So our locations in the southern part of the state, we are very rural, as Anna was talking and Michael were mentioning. We do a lot of rural care. That's small towns, small cities, but also massively rural communities. And we are in some of those areas that historically have had a variety of morbidities and issues. And you can look at that when, in this case, how we're doing it is to try to place in as many counties as possible a location that our folks can go to rather than them come to one of our 3 hub sites. So we are able to put 11 satellite sites in our region, and we're able to use spaces provided by Department of Public Health, some FQHC partners, and also the University of Alabama Birmingham helps us with space in Selma, Alabama. And it's very much needed because, as you can tell by this map, we are in that very heart of the area for HIV for Alabama, and that is very small town rural and in the southern part of the state. And part of that one is Alabama has over 65% of the folks who are living with HIV actually do not live in a major metro area. They actually live in small towns, small city, and rural. We're very different from a lot of places where it's very metro and urban centered. And with that in mind, unfortunately, those counties you're seeing there are some of the areas that are some of the poorest counties in the state of Alabama, not just for poverty related to the state, but also we have counties that nationally are some of the poorest. So what you have is HIV as well as a lot of health issues in very poor counties, which doesn't surprise anyone when we all know that poverty and poor health care outcomes unfortunately seem to go hand in hand. And then to add one more piece to it, we layer on that our health professional shortage areas in Alabama. We currently are in a state that has only maybe 5 counties that aren't considered. And then those very dark blue counties you see there are areas that really have no providers of any kind. We're not talking about HIV specialty. We're talking about any kind at all. And so that just puts us at a very disadvantage, especially if you add on the fact that our rural hospitals continue to close. Alabama made a choice to not expand or modify Medicaid, and so those rural hospitals are bearing the brunt of that, and of course the people in those counties are. We've struggled getting state and local leader buy-in about health care equity. My prayer is that maybe this current crisis may open some eyes, so we'll just try to do our best to make sure they remember this as they start looking at our future. And then we have high rates of uninsured people. Oftentimes rural communities have even higher rates of uninsured than in urban centers. And then you add to it the fact that there's not so much of a catch area. There's no safety net to help them out. That makes it even harder in rural culture. And speaking of rural culture, one thing I always make a point of is as we try to deal with rural people and help rural people, rural culture is not a preventative health care model culture. Rural people believe in crisis only. And that's a generalization, but for many people worldwide, they find that. So what we're dealing with is to try to go in and do some health care information to be able to help them with understanding why preventative care is important. And then the last thing I'll note on this one is we do have technological issues just based on broadband that I'll talk more about in just a second, but that is limiting a lot of people in the United States who are trying to serve in underserved areas when broadband availability is very limited. So we have a model that we call Alabama eHealth, and that model was predominantly based on the idea of providing care using most up-to-date technology. It was developed out in 2012 is when we started putting something together and actually started using a program that had 2 other sister organizations, and those were Thrive Alabama in Huntsville, Alabama, and Watley Health Services in Tuscaloosa. And so our whole project was to try to cover 50 of the counties of the 67 counties in Alabama. And so in essence, we just wanted to have a rural satellite system that could link in to a medical provider who could be based at one site and then cover as many people as possible. So when people look at telemed for MAO, what we're really discussing is a video chat that has a doctor or a nurse practitioner on one end, and on the other will be a recipient or patient. And in our service thing, it's different than the ECHO model because, as you noted earlier, we don't have providers in many of our areas. So we are using nurses to be able to go to the locations. They're there with our recipient, and they're able to do just like a full-on exam if they were in an exam room back at a hub site. We use high-definition cameras. We use about a 1080 pixel, which gives good clarity. We also use Bluetooth peripheral equipment that I'll go over in just a second. And then people often ask, well, so how secure is it? So we use a 256-bit encryption, and that one actually matches the level of the U.S. Department of Defense. So we're pretty secure in that, not only just from a HIPAA standpoint, but just our own being comfortable on what we're doing through that system. In our early part, we were using screens that were looking like this, nice, but not as much clarity. It kind of looked very distant. And then we moved to our model like this where the provider has the laptop set up, the individuals on the other end. We can make the screens as big or small as we like. The pixelization is incredibly good, and that's been incredibly helpful too. As people are talking at some point, they begin to almost not notice that they're talking through the camera because it can become even more intimate as the pixelization becomes more clear. And these are the peripherals. So at our sites, we will have, in the rural areas, we'll have a cart, and that cart can be maneuvered at any point. So if our hosts decide they need more space, we can move that to one area and move it to the other. It has a camera on the top. Every part of what we serve on use these Bluetooth related peripherals. The stethoscope you see there the physician or nurse practitioner would have one. On the other end, the nurse would have it. And everything that's being done between the two with those stethoscopes, the provider can hear exactly what's going on as the nurse is using it with our recipient. And then the other part you see is an otoscope, dermoscope, the thing is called a horoscope, that will allow us to be able to get that image. We can keep all of this under our electronic medical record. It's captured at that time, so you have it to be able to put in electronically, and they're able to see everything as they're going along doing the exam. And so the things we're using at this point are medical care. We do the initial visit always in person. That's a requirement that was set up in Alabama, but we wanted to do that anyway to develop the relationship. At no time are any of our recipients bound to having just to do telemed or telehealth. But what we found is when we introduce it, we always come back in a rotation with our travel team, but they always wind up going and using the telemed, because if they miss an appointment, they can always contact the nurse. The nurse can go back and meet with them on a later day and link to any of our providers in our system. So it adds a lot of flexibility in transport, limited areas, especially in rural communities, but also in urban areas could see the same. We do psychotherapy and addictions counseling through it. We have an in-house pharmacy, so our pharmacists are working with pharmacologic management with our recipients, and I'm happy to say they can do that with all of our recipients, including the rural. And then we're doing social work services, which is also a great piece to add to our service delivery through the more rural areas. And we have a registered dietitian on staff, and she's able to do nutrition therapy utilizing the technology. And then if we have an inpatient or a patient telehealth consult that we need to link with a provider outside our system, we can, because we do have a bridge set up that we can do other points outside our structure, and that's been useful for working some with UAB and some other programs. Demographically, I just got to point this out. At the end of 2019, we were running about 2,038 individuals for HIV-specific care, and in that number, 262 were being served by the telehealth. I want you to take note, the viral load suppression among our telehealth patients was actually a little higher. It's at 90.2 over the 88.4. And then our retention rate just for that year was at an 80.5 on the telehealth only and an 80.3 under the clinic. If I expanded that out and looked at the 5-year study we did that we pulled data in from 2019, we have served 4,835 telehealth contacts. We had 912 patients that were served, and in that, over 90% expressed extreme satisfaction with the care, with the next being satisfied, no dissatisfied. We had 93% virologic suppression and 89% retention in care for all the telehealth. And I just make a note of that because people wonder, does telehealth make people not feel comfortable? And my response is no, because they apparently really seem to take more time to come to their appointments because we can kind of maneuver it around their needs. And just 2 real quick notes here. We saved 662,000 miles of driving miles for our patients. Rather than them come to a hub site, they were able to go to a satellite. We also, from our standpoint, over 11,000 hours of total drive time, which benefited not only the recipients and the patients, but us, because I was not sending people out driving 2 hours one way and 2 hours back. We can rotate doctor or nurse practitioner seeing patients and recipients at one site, then come back and see the patient in the office, then send another patient out in one of the other sites. And I know all that sounds too good to be true, but it really does work. In that period of time, we really saved about $361,000 in driving expenses. And for a nonprofit, that is a huge, huge deal. And lastly to note, the cost that you can see, you can do hardware codecs, and we can talk more at the Q&A, but our hardware codecs can work quite well. That's an in-house based program that you would have control over. You can do a starting price of about $4,500. That would allow you to kind of get started with a 1-year maintenance piece. You can do a full cart that you saw earlier for about $8,500. And then we have things called convene units, which will set up on a desk, and particularly for any individual doing therapy through it, it's got great pixelization. The camera's attached, and you actually get better quality than you might with just a regular laptop. That price can go about $3,800, but if you use it more for medical, you're going to see more cost applied to it because of the peripheral cost. You also have software codecs, whether people are using Zoom or other, and they are able to do that fairly easy on the cloud-based programming. And the key to that, right now, the HIPAA regs, as Anna was saying, have been relaxed, which is wonderful and allowing a lot. But to really be comfortable, if you want to make sure that you're staying HIPAA compliant for the future, always make sure you vet out those platforms to make sure that they truly are HIPAA compliant, because there's some out there that are not, and you would not want to use those. I'll make a note, third-party payers are becoming more and more open to this, and they're going to be even more open because, as was discussed, COVID-19 has been a game changer. And my prayer is it'll be a game changer for all of our futures, that we could do a lot more if we can have some parameters to allow it. We currently are allowing our medical providers to be at home and being able to serve from the home-based program. We use a real presence desktop piece that's still under our secure system, and we're able to link our providers with our recipients by mailing or sending out a link to the recipient, and he or she can then go direct to their doctor. We're still not able to do the Bluetooth and, of course, in that process, but at least they're seeing their provider and keeping into the care model. Behavioral therapists and social workers are now assisting from their home offices, which as an administrator is helpful because I'm not exposing them. And then our pharmacy is doing a lot more mail order medication, and we did it before, but now we're just ramped it up. And in that, we're doing the telehealth consults through our system. And one thing I want to mention to everyone, and this is, again, a prayer for the future, one of the things that I hope one day to see is that people can do what I call suitcase unit care. And this is just an old model that probably rural docs and old-time docs used to do, and that is they would go to the home. Well, in this case, I foresee a chance for nurses or a community health provider to be able to go to a home with a suitcase unit and have the peripherals that they can link their doctor and nurse practitioner PA in to see that patient right on site. If we can do that safely and securely, I think that would help us tremendously to be able to ramp up and increase getting people into care. We could absolutely see a chance for retention numbers to skyrocket, which would be good. But more importantly, we could get that viral load down. I think there's a lot of potential right now, and out of something horrible that COVID-19 is doing, if we all really look at this and say, so let's look at how we can do things even better, not only now, but as the months come out and we get back to whatever the new normal will be. And please know that MAO has been there with the telemed. If anyone needs just some follow-up to vet out whether this is for something for them, please know that HealthHIV can assist them. We can also assist you with our internal telehealth resource center. We'd be glad to have our folks talk with you just to see if it's worth the investment before you spend any money. Thank you all. Thank you, HealthHIV, for having me on today.
Great. Thank you so much, Michael. And we will make our contact information and Michael's contact information available after this presentation so that you all can follow up around additional capacity building assistance in these areas. I'm now going to transition to our next speaker, Dr. Ritu Graywal from UF Health Family Medicine and Pediatrics, Bay Meadows in Jacksonville, Florida.
Thank you, Anna, for the opportunity to speak. I'm very excited to share with everyone our project here in Jacksonville, Florida, how things have been going, and what has shifted over the past few weeks. So welcome from Jacksonville, Florida. We're super excited to be on this call. Our project centers around our HIV provider in our region, our health system, which is UF Cares. UF Cares is the largest provider for HIV services in our region. So obviously we're in a urban environment, so patients do have choices, but the largest healthcare provider for HIV patients is our providers of UF Cares. So A little bit of background about our program. So telemedicine in general at UF Health Jacksonville started in 2017, so it's still fairly new. The first department to take it on was actually our neurology department. They hooked up some iPads in the back of the rescue units and were able to implement a telehealth program for stroke care, which dramatically improved survival rates. And then the program expanded in early 2017 to family medicine, so all of our primary care providers, myself included, were able to train and start seeing patients by telemedicine. But really the care was sort of limited to primary care. We really didn't have any specialists get involved. In September of 2017, we were fortunate enough to be awarded some funding from the CDC for a 3-year project to basically tailor our existing telemedicine program for patients living with HIV. We specifically wanted to look at, would this program work here? You know, patients living in rural settings may have limited choices, but in the urban setting, they don't. They can go see a private practice doctor if they wanted to. They don't have to use UF Cares. So there, you know, some of the differences are there from the urban versus rural environment, but many of the barriers are still the same. Our goal for this project over the 2-year implementation period was to see at least 200 unique patients living with HIV via telemedicine. And so I'll update you on how we're doing with that. So we were very fortunate that we had basically a full year to get our services up and running. During that year, we did a lot of background work trying to get our providers and patients up to speed and ready to go. Obviously, that's not the case for many of you out there. You're just like, how do I get this going right now? And we'll talk about ways to do that. But some background information about our project. So our electronic medical record is Epic, which is probably one of the biggest ones used in healthcare right now. In order to utilize a visit with us via telemedicine, patients have to have some technical capabilities, and that includes having access to our online patient portal, which is My UF Health or My Chart, which is what comes with Epic. So they have to have some sort of a login to get into that, which will send them a link to their telemedicine visit. Up until just recently, we were using a VidYO platform, which was integrated into our electronic medical record system. So on the provider side, it was super easy. We just had to click into the visit, and we were there. And same thing on the patient side. They would click into the visit from their patient portal, and they could get into the visit. In February 2020, prior to all of this happening, we actually updated to Zoom, and so it's still integrated into our system. On the provider side, nothing has really changed. On the patient side, there is an additional step now where they have to download the Zoom app as well, and so that's changed a little bit, but it's actually gotten better, as I'll talk about later on, because one of the issues we had with the VidYO was some of the service plans and carriers had issues. So patients on certain plans did fine, and some of the cell phone carriers did not do well with the VidYO. But now with Zoom, we really don't have those issues anymore. So they needed those technical capabilities, right? Patients have to be able to access telemedicine somehow. So, and I'll explain how we're doing that. But we also came up with some criteria for clinical criteria. Of course, we didn't want to see anybody with any acute or life-threatening illnesses. That kind of makes sense. Some of the other things that we decided on was we wanted patients to be relatively medically stable, meaning we wanted to have our patients have a CD4 count of greater than 200 cells. So if someone had one lower, they were not eligible for a telemedicine visit. Any unstable chronic disease or any issues with chronic pain where they needed narcotics to be prescribed was not allowed, and that was the case up until just recently as well. So how this project works, we basically need to get our patients funneled to UF Cares. So those who had their own devices, either at home or at work, if they had a smartphone, if they had a computer or an iPad, and they were sort of technologically capable and met the clinical criteria, they could go ahead and do their visits from anywhere, wherever they were, whether it was home, work, a friend's house, it didn't matter. But we wanted to have an option for patients who didn't have the technology. And so we partnered with our family medicine department, which that's where I am, and also some community-based organizations. And so that patients would have options. So if they didn't have the technology, they could walk into any of our family medicine clinics, and we have over 30 now in Jacksonville, or one of our several community-based organizations, and just walk in and say, hey, I have a virtual visit with UF Cares. They didn't even have to be a patient at those family medicine clinics. They would just walk in, and we had iPads at each of those locations for them to use. If the patient is also a client of that community organization, there was a setup at each of those organizations for the patients to use there, but the case managers at these organizations could also take the iPads out to their clients' homes to have the visits too. So these are just some of the services at UF Cares, kind of very comprehensive. We're, again, one of the, basically the largest in this area, the only provider that provides pediatric care for HIV, but also includes, we have gynecologists that come to UF Cares, psychology, pharmacy, nutrition. And so, actually, let me just go back for just a second. So you can see, as I know it's very tiny, but UF Cares is located at our hospital in downtown Jacksonville, which on this slide now you can see those little blue dots are all of our family medicine sites. So they're spread out all over the region. But right in the center of the screen is kind of where UF Cares is located. And so all of our family medicine sites have been trained to be a presenting site for this project. So everybody knows how to handle a patient coming in who says, I need to connect with my provider for telemedicine. And then our community-based organizations, we have several. So Jasmine, who is one of our Jacksonville area sexual minority youth network, they're probably the largest provider for case management services for patients who are of the adolescent and young adult age. River Region, which is a substance abuse treatment facility. The North Florida AIDS Network. We have an independent pharmacy who's partnered with us to act as a presenting site. That's Edgewood Pharmacy. And then also the Nassau County Health Department, which is located kind of north of us, since they do not have any HIV providers in their county. So, this project, again, went live in September of 2018, and early on we did have quite a few challenges. The biggest probably centered around reimbursement. Florida, as of a few weeks ago, had no parity laws for telemedicine. So, there was no reason for any commercial or secondary insurance to pay for telemedicine. They weren't forced to. We got a little fortunate in that in December of 2018, Florida Medicaid approved telemedicine as an approved modality. And then, through the efforts of the folks on this project and having that whole extra year to kind of get this project up and running, we had worked tirelessly with our local TGA to get approval. So for telemedicine for Ryan White, which actually happened as of March of 19. But the other insurances were all variable. And so thankfully we had funding from the project to be able to reimburse our providers for providing care if their insurance company did not. One of the other challenges that we noticed during the first year of the project was really having a lack of dedicated staff. And what I mean by that is while we had project staff working on this, everybody had other roles. And so it was really hard, no matter how much we tried to delineate roles for everybody, they had 6 other things on their plates. And so telemedicine always sort of fell to the bottom because they had, all these other things to do. We noticed that, especially early on, it was very difficult to get patients engaged. They were concerned about privacy on these platforms and, is my information going to get out there? We also had to work with providers, especially, the ones at UF Cares were very reluctant at first to get on board because, trying anything new is difficult. And so being asked to now see your patient virtually at first, until you try it, you don't really know how it's going to be. So it took a little while for them to really come around to it. And then again, as I mentioned earlier, there were a lot of technical issues on the patient side, especially with the VidYO platform, just because of their cell phone providers. some of the successes early on, we were able to come up with plans for how we could identify appropriate patients. So we utilized our weekly case conferences, which was an interdisciplinary team review, where they looked at the upcoming week and actually 2 weeks and identified patients that might be appropriate for telemedicine. And then they would call them to schedule and see, would you like to convert to a telemedicine visit? So that actually has worked out well, and that's continued to work well for us. The other thing was, again, because we noticed that we had issues with dedicated telemedicine staff, we actually hired a telemedicine navigator who works at UF Cares now full-time, and her job is basically to help patients sign up for telemedicine, get them on the MyChart platform, help with technical assistance, troubleshooting for both patients and providers, help with scheduling, and that has gone a long way since she's been on in December to help our numbers. I know this is a little hard to see, but some of the other project successes that we've done, and again, this is kind of more for a long-term project, but this is something that we wanted to have so that this project will sustain well after this, the CDC funding is done, was the creation in our electronic medical record system of kind of a flag that pops up anytime you have a patient who has HIV. If their chart comes up and you're either an HIV provider at UF Cares or you're a primary care provider, this little note will pop up that says, hey, do you think this patient might be appropriate for telemedicine? Remember, these are the criteria. And then if you say yes, great. If you say no, they may not be appropriate, a little flow sheet pops up to ask, well, did you offer the patient a visit? And if not, why not? And did the patient not have the appropriate technology? Are they seeing an HIV provider outside of UF Cares? But that way we could track and see what the rationale was for patients who were not choosing to use virtual visits. So this has been very helpful for us in terms of developing strategies once we kind of are able to analyze the data. So some updates on our numbers. Again, this is a project that's still in its infancy, but as of August of 2019, so about 1 year into our active phase of the project, we had conducted 71 telemedicine visits with 58 unique patients. So a long way to go to that goal of 200 unique patients. But remember, for us, we really didn't start up until March because we were waiting on Ryan White approval. So the first 6 months were kind of a no-go for us, essentially. As of February 2020, so right before the pandemic sort of started up, we had increased our numbers quite a bit. So 178 visits were conducted with 115 unique patients. And really we saw a fairly significant bump around the time when we hired our telemedicine navigator. Again, we think that she's done a great job of just getting patients engaged and really, interested in doing telemedicine. Also, kind of prior to the COVID outbreak, we did have some ancillary services. So psychology, we have a psychologist at UF Cares. She had done 3 visits and with 2 unique patients via telemedicine. And then our community partners, the only one who had really utilized was our partner in Nassau County for a variety of reasons. But our Nassau County partner had done a few telemedicine visits with clients from the house, but they only maybe had 3 or 4 and kind of had exhausted the patients who were interested. So we've obviously had a lot of changes in the last few weeks, and remembering that UF Cares is a hospital-based clinic, so in order for patients to come to UF Cares, they actually have to go in through the hospital, and UF Health has very much consolidated. There used to be 20-plus entrances for patients and staff to get in, but now essentially you're either being funneled in through the emergency room or through the front entrance as a patient, and that can be very overwhelming, especially as people are getting temperature screens and you're kind of being stopped. It's not something that we necessarily want our patients to have to go through. So as a result of that, we decided as a team that we would just loosen the eligibility criteria. We felt comfortable enough at this point, we had done enough visits to basically say any patient is eligible regardless of their CD4 count. and that basically going forward, all of the patients that were scheduled for the upcoming weeks have been either converted to a telemedicine visit or try to be rescheduled for later on, maybe this summer, where hopefully we'll be in a better place. And essentially, the only patients coming in right now are those who are receiving kind of more urgent care or emergency care, who really need to be seen in person. But we're really trying to limit the patients who are coming into the clinic. So the other updates are, we have seen an increase in telemedicine from some of our community partners. Again, Nassau County has been kind of the leading one. They have had an additional uptick in patients who have decided to participate in telemedicine. The other nice update, of course, is the reimbursement. So we went from basically having nobody except for Ryan White and Medicaid approving telemedicine to now everybody approves telemedicine, which has been fantastic for us, and we hope that it will continue once this pandemic has ended. Our connectivity issues have mostly resolved with the use of Zoom, and so that's been really good. The other update that I didn't put on here was that we are also allowed to see new patients this way. So initially we wanted only established patients, but this is across the organization. So new patients coming into UF Health, whether they're going to UF Cares for their HIV care or anywhere else, can now be seen by a virtual visit as well. So as of, this past Monday, we have actually had a huge increase from a month ago. So our numbers have gone up to 257 total visits with 168 unique patients. For the ancillary services, our psychologist has also had a bump up in her visits. So this is just really over the past week now she started seeing more patients. And also over this current week, we've added pharmacy and nutrition online as well. So we should have data on that very soon, which we're excited about, to be able to offer our patients, every service that they would get in the clinic from their homes or wherever they are. And I think that is about it. Thank you.
All right. Thank you so much, Dr. Graywall, for your presentation and for sharing the program in Jacksonville. And thank you to Michael as well for sharing about the program in Alabama, both really helpful examples. So we now have time for Q&A. Thank you to everyone who has submitted a question so far. We are tracking those and will facilitate them to the speakers. And you can access the Q&A box from the navigation bar at the bottom of your screen. So we will start with this question, which is more specific to the Jacksonville model. Dr. Graywall, would you please outline a bit more what the telemedicine navigator does within your agency and what the thought process was behind creating that position?
Sure. So we noticed that over the first year of implementation of our project that, we were trying to ask multiple people to do bits and pieces here and there, and we felt that having somebody in the clinic full-time whose purpose was basically to get telemedicine off the ground and serve as a resource for both patients, clinic staff, and providers was kind of the way to go. So we hired a telemedicine navigator in December, and again, it's gone really well. So what she does, she participates in the case management conferences every week, and so, when it comes time to make the phone calls with, these patients look like they're ideal, she does that now rather than putting that on somebody else, because we were noticing that sometimes the patients would be identified, but they may not have gotten a call, or there wasn't much follow-up if the patient said, no. So she's been helpful with that. She also goes around in the clinic and talks to patients about the benefits of using telemedicine and how easy it can be. And if, patients have hesitations, or maybe they don't have the technology, she'll go over the community partners with them, or she'll go over the family medicine clinics where patients can have their visits, and helps them walk through step by step. I think that's the biggest thing for us, was that everybody in our clinics are so busy already. To add one more step to their process, it became very difficult. So having someone who can really, they understand the ins and outs of how do you get a patient signed up, what does the patient do to get to telemedicine, and that she can take the time to go through and do that has been super helpful. And I think it's actually helped the staff tremendously too, not only because they don't have to do as much of that, but actually I feel like they've gotten better at what they do and being able to actually assist because they have a resource right there in their clinic.
Perfect, thank you. So this next question is for either presenter. Could you speak to some methods that you've used to prepare consumers for transitioning to telehealth or telemedicine appointments from in-person appointments?
Doc, do you want to go first?
No, go ahead.
For us working with rural people, as you can imagine, the question we had along the route was whether that would be something that they would even remotely be comfortable with. And so we introduced it as that potential option, and how we put it out there was that this was something that if they should happen to miss an appointment, we could do things a little quicker and be able to get back to them. Whereas previously we might have our group, which oftentimes was a van with a doctor, nurse, social worker, et cetera, going through sometimes every other week, sometimes once a month. So we just offered that option. What we found, too, is always to say, you do not have to do this. You know, if you're not comfortable, we will set you up for appointments. We'll get you wherever you want. So giving them that option to say, I can choose to do this, I think makes a huge difference. After that, what we found, they got into it. They to a person, they would say, we forget that the screen is there because they're so focused on talking with the nurse who's with them and then talking directly with the recipient, the doctor rather, or the nurse practitioner, that they really do just get into the moment. And I think the technology makes them feel like they really are getting this extra boost on care. Even though it's the same care we would give in person, there's just a lot more technology involved. So I think it gives them an additional comfort that they're getting the best possible care that we can offer.
And I would echo everything that Michael said. You know, we've never forced the issue of telemedicine on any of our patients. We've, you know, encourage them to use it, and again, you know, the patients who may have been hesitant are all of a sudden really embracing. We're actually, as part of this project, we've been conducting focus groups. I wish I could tell you I have the data, but they've just happened over the last few weeks, so I don't have that yet for you all. But to talk to both patients who have done telemedicine group visits and then patients who have not done telemedicine visits to kind of compare and see what the angst is. The interesting thing is, though, we kind of had to do our telemedicine or a non-telemedicine focus group very quickly because most of the patients that were signed up are actually now scheduled to do telemedicine as a result of this pandemic. And so in many ways, you know, patients who have been reluctant or hesitant for whatever reason are now embracing telemedicine. And I feel like they will be happy once they've actually had a visit and seen what it can do for them.
Great, thank you so much. Would either of you be able to speak to how you handle labs for telehealth patients or recommendations that you have for that?
I can speak for what happens in Jacksonville. So, you know, it all depends on the patient's insurance company, of course. So for our patients who have Ryan White, they do still have to come to UF Cares for labs, but then the telemedicine component means they don't have to come back for lab results necessarily. They can do that virtually, so it's one less contact. For our patients who have other insurance programs, though, what they can do is actually order the labs either during their telemedicine visit or prior to, and so the patient can go to wherever they need to go, whether that be Quest, LabCorp, and get their labs done either ahead of time or after the visit, and then follow up with the provider. So there is that component of it too. I wish we could have home labs. That would be fantastic, but we're not quite there yet.
And I concur exactly. That's exactly how our structure is working.
This is Michael Schenkel chiming in. Michael, there was several questions about the use of satellite sites and a lot of interest in your Bluetooth stethoscope and other monitoring service kind of services. Could you just explain that a little more? Now, I know you're doing more in the patient's home at this point, but can you explain that a little more for the users?
Sure. And so I'm just making sure I'm clear, too, for them, when I talk about our satellite sites, they are clinics sites that are dispersed throughout our structures, and they are located on the premises of collaborating partners. So we could have a program at the county health department. We're doing HIV-specific care for a few of the FQHCs in our region because we cover about 18,675 square miles, so we're in a vast area. And so how we use it, they allow us that spot. They let us place our units there, and then we have the nurse that goes to the site, and he or she would be working with our recipient at that site. The Bluetooth stethoscope, which is a fascinating piece, is actually, we use the laptop computers to be able to do a connection, and everything is linked in. But the Bluetooth stethoscope is mated to the stethoscope that the nurse practitioner, MD, is using at the hub site. So everything that the nurse is utilizing when they're working with the recipient is being heard by the physician nurse practitioner. And even to the point that they can amplify it. If it seems too light or too quiet, they can amplify it up, which is great. And the same thing with the otoscopes and dermoscopes. They're able to use it, and the doc or the nurse practitioner directs their nurses' help to say, okay, let's do here and here. And what we found is it does extremely well. And why that's good is because we can flex that out, and I use this also, too, with the satellite systems. If a recipient says, I just am not comfortable going in my own county, because in some of the rural counties, that people know each other extremely well. People got relatives behind the front desk. Well, then we can just shift them over to the county next to it or around, so they're still not having to travel massive distances and still being able to use all those peripherals into our structure to get a full exam like they would if they were at the hub site in the room with the MD, nurse practitioner.
And thank you. And is the patient, when you're using that stethoscope, is the patient able to hear as well?
They could actually. They could set it up to where it can be amplified in that room. They absolutely could. And they can see if they choose to as well. They can position the screens, et cetera, to be able to do things too. One thing people do ask about is, well, how good is that? And one of the things we knew, we did this kind of a run-through with some of our folks up at UAB, and so our doc was working with them, and they had the nurse up there, and asked the nurse was moving the stethoscope from one side of the chest of her own chest to the next. And all of a sudden, our doc said, hey, could you go back just a second? And she just smiled and says, yes, I know. I have a little bit of blip there. And he picked it up immediately just by the transition. So that helped us to feel more confident in that fact that that thing was really good. And it was actually picking up something, including a little bit of a arrhythmia piece going on. So that helped us to feel even more confident.
Excellent. Thank you for that. And this is for, I guess both of you could answer this question related to signatures, whether that is for a consent to treat the patient or a form that has to be signed if the patient was being cared for under a Ryan White line of funding. How do you go about implementing those activities?
So actually that's a great question, because that was one of the things that came up as we were planning to go with telemedicine, was how are we going to get the treatment services plan signed by patients remotely. And at the time when we went live with our project, we didn't have any sort of capability of doing that within our electronic medical record system. And so we actually, for this project, purchased an agreement with DocuSign. So it was a little bit clunky and cumbersome for us initially because the CSRs, who are our front desk check-ins, would have to, get out of sort of the medical record and then go into DocuSign and then send that to the patient and have them sign it. And so it was a bit of a clunky kind of fix, but it worked. But it highlighted the issue, and that was yet another reason actually why new patients were not allowed to be seen via telemedicine, because they couldn't sign all of their consent forms to be treated, even just the general consent forms for UF. So this project actually brought that to the attention of UF in general. Since our latest upgrade with the Zoom platform, but also just several system updates within Epic, we can actually now do all of that electronically within the patient portal. So now that's what's allowed us then to be able to do new patient appointments through virtual visits if patients want to. And then they can also now sign their agreements. So we're very fortunate that Epic has made that possible for us.
And you're also seeing more and more in the current structure where the providers, particularly the third-party payers and also Medicare, Medicaid, are allowing a lot more to be done by verbal consent. You just have to make sure you've received it and that you've documented it. So the question mark will come at a later date. Will that be something that could be carried over in some form or fashion? And we don't know. But at this current point, that's been very, very helpful. Although we still, like Doctor was saying, we still see our folks initially in person, but that does give that even more of an option from a standpoint. And a lot of the paperwork for social workers and others, we are seeing Ryan White Part B, Part A's, et cetera, allowing for proxy signatures as long as you have a document, whether it's an email or a verbal saying that I will allow this to happen, that's allowing them to get their meds processed through their ADAP programs quicker, and also to be able to do other things, housing with HIPAA, et cetera. So we see a lot more flexibility right now.
Terrific. And I guess we are at the top of the hour at this point. We did receive a lot of questions around the provision of telehealth for Ryan White programs. This is an allowable activity under Ryan White, and I would like to refer people to Policy Clarification Notice 16-02, which describes the use of telehealth as an approved methodology for the delivery of Ryan White services. You should, in fact, check with your local recipient, if you are a subrecipient, to ensure adequate steps are being taken to be in compliance with the program. One other question relates to ensuring confidentiality of your patients when they are utilizing telehealth. Can you tell me, are there certain things that you have instructed patients to do in order to improve or help protect their confidentiality during a telehealth visit?
Yes, I can speak to that. So we, as part of our project, have developed some patient education materials that are available for the patients either at the clinic that they can take with them if they're interested in signing up, or we send them to them electronically. And I want to thank HealthHIV and the CDC for helping us develop these. But there are a lot of tips and tricks that we've included in there for patients. So obviously most of the patients who are using our project are using it from their home or other places. And so we want to make sure their privacy is protected. So some of the things that we recommend are using earbuds or a headset so that the conversation is more private. Obviously, trying to be in a private location, if at all possible, be in a room somewhere by themselves. And all of the clinics that serve as presenting sites, they of course have the iPads in places where patients and providers are not walking in and out of all the time, so that the patient who's in there utilizing it has their privacy intact. But other things, we've had some interesting episodes that have occurred. We've had to put recommendations on there like, do not drive while you're having a telemedicine visit. And people might think it's funny, but it has happened multiple times, actually. So we've had to stop visits, or we've had patients who have tried to use the virtual visits while riding the city bus. And so we've told them, this is not a good time. Why don't we wait and reschedule your visit at another time? But those are the kinds of things. Also, just having them check their network and their plans to see whether or not they can do the visit over their cellular data, but really trying to ask patients to use Wi-Fi when possible. But maybe, we've made some recommendations. For example, if a patient doesn't have Wi-Fi, they could sit in the parking lot of McDonald's and still get the Wi-Fi signal to use it, but yet not be inside a public space. So those are the kinds of things that we've found have been helpful as far as protecting privacy for our patients.
And our IT group decided, we have an internal IT structure, and we made a decision to keep everything within our hardware codecs and to be able to do it by sending links. It's still under our bridge system, and that's been an extra protection for us, because my IT group was just like, no, even during the current scenario, let's still use our infrastructure, because that way they can offer more protection during that time.
Terrific. And Dr. Graywall, I don't know if you can answer this from an institutional perspective, but what has UF Health done with the Zoom integration, if you know, with the potential issues that Zoom has come out about Zoom having some HIPAA challenges?
Right. So I think it sort of depends. If you're using Zoom just on your own, it certainly could have some HIPAA challenges. The way that we have it set up, it's integrated within our electronic medical record system, so the only one getting the link is the patient. But there are ways that you can actually limit. I know that like our faculty who are teaching down at UF in Gainesville, who are doing the undergraduate and graduate level courses, are using Zoom, and they're having the same issues as everybody else. And so there are ways to limit screen sharing. There's a way to limit that to just the host only, and the host would be the provider that's linked in. So that way the patient couldn't share this, with somebody else. There couldn't be another person joining on. There's ways to require authentication to join a Zoom session if you needed to. You can actually lock the meeting. So once a provider is in with the patient, there's a way to lock it so that nobody else can come in. Even your front desk couldn't get back in if you lock that. So there are ways around it. You just have to, kind of look for those kinds of things.
And what we will do, thank you for that, and what we will do after this is we will be sure to gather some best practices and some links of how that is being resolved, and we'll be happy to share that with the group and on our webpage, healthhiv.org/telehealthhiv as well. I would like to thank Michael and Ritu for participating in today's webinar with us. We really appreciate your expertise. I know we have lots of questions that we've not been able to get to today, that we will be assembling a Q&A document post this webinar and getting some of those questions answered for you. I would like to call your attention to Synchronicity 2020, the National Conference on HIV, HCV, STIs, and LGBT health. Synchronicity this year is going to be virtual because of the COVID-19 pandemic. It's going to be happening June 23rd through 25th at a computer or mobile device near you. You can find out more information at sync2020.org. And if you have already registered for the in-person Synchronicity Conference that was supposed to happen first in May and then December, those conferences are now virtually, and they are happening June 23rd through 25th. We're going to be posting more information on our website about conference fees and ways to access that virtual content in the coming days. I would like to also thank you for your participation today and for all of our frontline healthcare staff members who are out there helping to combat the COVID-19 pandemic, and for your use of telehealth in expanding services and keeping access to people living with HIV. After this webinar, we would like to invite you to complete the evaluation and survey of your organization's telehealth services. We'll be sending out a link via email immediately following the webinar. And within 24 hours, this webinar will be archived on healthhiv.org/telehealthhiv, where you can also access other resources and request capacity building assistance. I'd like to thank everyone for your participation, and we're going to be having additional webinars on telehealth coming up, including telehealth and PrEP, and telehealth and HIV testing. Those will be coming up shortly, so stay tuned, and you'll be receiving an email from us about the evaluation and upcoming webinars. Thank you again, and have a great day.